This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our HealthyU Webinar Series. Today's topic is problem with your bottom. At any time during the presentation, please feel free to answer any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is Dr. Joseph Bornstein. He's a double certified colon and rectal surgeon with expertise in minimally invasive and robotic surgical techniques. He specializes in treating conditions affecting the intestinal tract, colon, rectum, anal canal, and perineal area. Dr. Bornstein, I'll hand it off to you and you can start whenever you're ready.
Hi, thank you all for being here today. Just going to start off with Oprah here telling everybody they get a hemorrhoid because we're all born with hemorrhoids, and we're going to go into a lot of that today, okay? So today we're going to cover a lot of different topics, but I'm going to try and provide a range of information that I think will be very helpful for you to have an idea of how to manage issues that you have. Okay, so we're going to talk about common problems with your bottoms. Before we get started on that, I just want to tell you a little bit about myself. I was trained mostly in Boston. I went to Tufts Medical School way back when, and then I followed that up by going to do my general surgery residency at the Mass General Hospital in Boston in general surgery. And then I continued at Mount Sinai back in Manhattan, where I grew up originally, and did my colon and rectal fellowship. Subsequent to that, I actually found love and moved down to Alabama, where I worked in the Gulf Coast in Mobile, Alabama for the last 10 years before coming back up to the Northeast. Some of the things I just wanted to share with you all about that experience. This was the hospital system that I worked at, which was Providence Hospital in Mobile. Something that's shown in the top left here, these are people known as the Mobile Trail Maids, who are the local ambassadors for the city of Mobile down in the South. And something that you might not know is the original carnival festivals in the United States. The original one actually that predated the one in New Orleans is in Mobile, which has the longest running carnival celebrations in the country, and they have a nice museum down there, and I got to participate in those celebrations. One of the other things I did down there that was fun and interesting was I worked for the Mobile County Health Department as the chairman of the board, and of course I took that position notably during the COVID pandemic. So a little bit more about that. Some people think Mardi Gras is just one day, but actually Mardi Gras is about to begin, and there's a whole month of it. And so some people may not realize, but there's actually dozens of parades that go on throughout the area. And you can see this is just an example of this year's parade schedule, which starts on Friday, January 26th and goes all the way till Fat Tuesday. On the top right, there's actually a picture that I took from when I was on the top of a parade float during the day, during one of the smaller parades in Mobile. On the bottom right, my wife actually participated in one of the Mardi Gras societies that was actually for St. Jude's Children's Hospital, and she was the MC of their Mardi Gras ball annually. So that was a nice thing for us to participate in with for medical charity. So moving on to the task at hand today, we're going to talk about common proctology issues. I'm going to talk about some of the symptoms that you can have on your bottom and how to think about what to do about that, what to expect when you come to the proctologist's office. I'm going to try and cover a number of anorectal conditions and how we think about treating them. There are a number I'm going to try and get through. I may not get through all of them. I may end up cutting short some of the ones towards the end because I'm going to try and be as thorough as I can. But there's quite a bit to cover. The first thing I want to get across is Dr. Google for anorectal problems can actually be a tad evil. because the symptoms that you can have on your bottom can be pretty universal, regardless of whether it's a benign condition or something quite dangerous. And so people can get unjustified reassurance by looking up, say, having some bleeding and thinking it might be due to hemorrhoids. Also, they can get unnecessary anxiety by thinking every hemorrhoid is potentially a cancer. And something I really want you to take away is that just a simple evaluation sometimes is all that's necessary to provide either reassurance or make sure that you're on the right path for your health. So akin to that, there's only a number of symptoms that really you can have on your bottom. You can have pain, you can have bleeding, you can feel like something's protruding, you can notice some seepage or soilage in your underwear, some itching, and maybe a change in bowel habits. And then there are a number of signs that I can see on exam, such as tenderness, some redness, or some thickening of the skin, or a feeling of a mass. And what I want you to take away from this is the number of symptoms are quite limited. And actually what you're going to see is that many of the diagnoses can almost have all, if not most, of the symptoms. So simply looking up a list of symptoms will not lead you in any particular direction, and they need a more thorough evaluation. In the office, I do ask specific questions about these symptoms, which can help direct what type of treatment people might need. I can ask different characters about the pain. I can ask different things about the bleeding, which might give me a reason to do different types of workups on folks. Importantly, when you go to the proctologist's office, I have a couple things that I really need to accomplish for patients. One is I need to make sure that people, given that this is a very sensitive area, we need to be understanding that people can be very embarrassed of it. People have very painful conditions on their bottom, and they can be very fearful of the exam, and they should know that our goal is to not cause excess discomfort, and there are many ways to perform examinations, sometimes even under anesthesia, if necessary, to be able to see what's going wrong. People can just have a fear of cancer and not want to get checked. One thing that's very common actually is despite the fact that these proctology issues are very common, people tend to think that they're very alone with them because it doesn't really make for good coffee talk. You know, it's very common for you to sit at a restaurant. You could almost overhear the table next to you, and you hear about neck problems, orthopedic problems, heart problems, but nobody really at the restaurant wants to talk about their bleeding hemorrhoids or the hemorrhoid that was removed. It sort of doesn't make for polite conversation. So surprisingly, when my patients, when I talk about this with them, and then they tell me that they mention they have one of these problems to a family member or friend, they instantly find out that many people in their life actually have encountered a proctologist at one point, but it's not something that they're really aware of beforehand because it generally is a fairly embarrassing topic for most. So again, it's my responsibility to keep people at ease and impart a concerned attitude. And of course, for those that are interested, we do have same-sex chaperones when we see people for these exams, which I think is critical and required. I get a lot of questions about, again, those things that can embarrass you, like, are you having your period? Are you having leakage? Your underwear could be saturated. You could have blood on your underwear. Sometimes people come into the office with gauze in their underwear for drainage. And they worry about, do they have to prepare? Do they have to use their bowels beforehand? They're worried that they're not clean. These are things that we encounter normally. There's no specific preparation you need for any initial office visit. Most things I can do, most evaluation I can do in the absence of any specific preparation. And if you didn't have the problem, you wouldn't have a reason for coming in. So more to expect on what we do at the office. A thing that's pretty important is we can actually give you a diagnosis a majority of the time with just the basic examination in addition to the history. And there are four main components to that exam. I inspect the anal canal and perianal skin. I feel it to make sure I don't feel any masses. I do a digital rectal exam to feel the inside of the anal canal where I can feel the muscle and any lesions on the inside of the anal canal. And then I do a visual exam, which can be done with something called an anoscope, and I'll show you what that looks like. And of course, there are more invasive exams where you can look further up the colon, and those are done selectively depending on what people's symptoms are. Of course, those are not done at an initial office visit. Any extra workup is generally scheduled thereafter. So you don't have to expect to be prepared for those things up front. It's important in colorectal surgery specifically to have a rational approach to workup. Many diagnoses are primary in the sense that some people just have big hemorrhoids and they're born with big hemorrhoids and they cause them symptoms, and when we see them, we know exactly the symptoms and the findings correlate very nicely together. But sometimes people will have hemorrhoids because they have an underlying problem that's new, like new constipation, or God forbid, somebody has a colon cancer that's causing constipation, which then leads to extra time on the toilet, which then leads to hemorrhoids. So it does take a thoughtful collection of the history and exam to decide if any further workup is needed. But you know, for one of the advantages to seeing a colorectal surgeon, of course, for these problems is that we are very thoughtful about what workup needs to be done, and we can, in many cases, protect people's wallets from unnecessary workup if on exam in the office, we can see exactly what the problem is. Just to emphasize this point again, I feel like to some degree this is fear mongering, but for what it's worth, simple complaints like having an itchy bottom, it turns out that there are a lot of conditions which can sometimes be associated or be causative for that. And when some people can be surprised when we do recommend on occasion more workup for what could seem like a minor condition, but it's because we can find much more nefarious things that could be causative for them in certain circumstances. A brief warning for anybody watching, there will be some graphic pictures. We are talking about anal conditions, so I wouldn't be doing it justice if I weren't showing you some pictures of that sort of stuff. If that bothers you, you could always turn the screen off and just listen for the time being. So to go again on the office visit, this is a bit of a dated picture of a standard office setup, but you can see we have a proctology table here where we do the exam. We have a light, you know, a light is necessary so we can see the area very well. Some offices come set up with endoscopy equipment there to be done contemporaneously. We can examine patients in two different positions, most often in the prone position on the proctology table. That's usually for the best way for us to see what we're doing. But on occasion, people's knees or orthopedic conditions don't lend themselves to that position, and we are able to examine people on their side or even standing if necessary. Again, the first part of the examination is I'm going to evaluate the skin, the anal verge, which is the area of darkened skin around the anal canal. And of course, I'm going to do a digital exam there as well. This is a picture of a standard anoscope that we use. It has a light, as you can see here, and this allows me to look at the mucosa on the inside of the anal canal. And of course, these are the scopes that I was describing before. This is a rigid sigmoidoscope, and this is a flexible one. The rigid one is used for a quick and dirty exam, mostly in the office. If symptoms warrant a look, I generally prefer the flexible one because the resolution is much higher. One difference, though, is that often these are done, the flexible ones are done in the endoscopy lab, whereas the rigid one can be done in the office. So I use the rigid scope more as a screening tool if I can get a quick answer that way. So before we talk about conditions, I just need to get everyone up to speed a little bit on the anatomy of the anal canal, and this will bring the salient points of that. So the lower part of the rectum here, you'll see this line over here is the circular muscle of the rectum, okay? The rectum is kind of somewhat of a hybrid between a bladder and a colon in the sense that it has some capacitance function. So you can hold onto your bowels and then move them at your discretion. And it has a circular muscle that goes around it, and that muscle continues and becomes the internal sphincter of the anal canal down here. On the flip side, your external sphincter is contiguous with your pelvic floor sling. So if you all want to experiment, if you try and squeeze your anal canal with the muscles that you can control, you can also feel a slight lift, and that's because your anal canal and your pelvic floor sling are a part of the same unit, okay? Some other anatomic features that are important here. There are a couple transition points which are key when examining some anal conditions. One is first on the outside here is where the darkened ring of skin is going to be. And then on the inside here is where the internal hemorrhoids will exist. And then there's a natural transition point where some of the internal hemorrhoids are up here and basically there's a transition where there are some glands and the nervous system is different between the inside and the outside, where you have somatic sensation on the outside here, and you just have visceral sensation on the inside. And what that means is that when you do procedures to the inside of the anus in here versus the inside you feel no pain, whereas the outside you do, because it's sort of like normal skin sensation, okay? So we're going to talk about a few specific disorders. I'm going to rush through some of the ones at the end, but we're going to talk about the most common ones that I see in the office, such as hemorrhoids, anal fissures, abscesses, and fistula, as well as rectal prolapse and anal neoplasm. There are many other topics we could cover, and we certainly could do a whole hour on any individual topic, but I'm going to try and give you a whole rush of stuff so you have some basic idea and understanding about the range of symptoms you might have and how they might correlate to a problem. So the first thing we're going to talk about is hemorrhoids. So talking about hemorrhoids, hemorrhoids are basically these vascular cushions on your bottom. They provide some bulk and assistance to your continence and actually act as a transition between the outside and the inside. They're kind of, the best way to describe them is like almost like a venous sponge, even though the blood is actually arterial. And they're not just like a cavernous collection of blood. You got to think of it much more like a network, and it's has some connective tissue and smooth muscle that helps to hold it up. Okay. People can have external hemorrhoids and internal hemorrhoids, and sort of mixed picture. So it's kind of like a box of chocolates. You never know what you're going to get. Some people will just have external hemorrhoids and small internal hemorrhoids, or big internal hemorrhoids and small external hemorrhoids, or sort of one big hemorrhoid that's kind of a mixed external and internal. And it can come in all shapes and sizes. The important thing is that the ones that are inside the anal canal generally do not have typical nerve endings. So you can pinch, burn, and squeeze them, and patients will not have any significant pain with that. However, ones on the outside, which are covered by normal skin, can cause severe pain when they have problems or when any procedures are done on them. So why do people get hemorrhoids? Well, some people, have hemorrhoid symptoms when they're very young, and that's probably somewhat genetic. They're just born with these large hemorrhoids on their bottom. Some people get them over time. And the reason for that is that just over time of use and them stretching, if you just imagine having this sponge, and that sponge is constantly stretched and unstretched over a course of your whole life, moving your bowels, maybe you have lots of constipation or do a lot of weightlifting, that certainly is going to add pressure to the area. You can just imagine that over time, your hemorrhoids can just get larger and stretch. I show this picture of the earlobe, which has been stretched here from a gauge earring, just to show that it's just a part of your body that can stretch over time. And it's why, some folks will get bad hemorrhoid symptoms in their 60s, 70s, and 80s, and they can worsen over time just from a life well lived. Just to reiterate about the symptoms, people can have a variety of symptoms from hemorrhoids. It very much matches the list I gave you before, as every condition essentially will. People can have bleeding, they can have protrusion of the internal hemorrhoids, they can notice seepage or soilage, especially when the internal hemorrhoids prolapse out and are touching people's underwear, and therefore they can see some staining. They can get some itching when some of that wet layer gets onto the perianal skin and irritates it and overcomes the natural moisture layers of the perianal skin. Rarely, when people have problems with their internal hemorrhoids, do they experience pain, because again, the nerve endings are different. The external hemorrhoids, on the other hand, usually can become severely painful if they get blood clot in the hemorrhoids, and that just happens because blood has a natural property that it will clot when it's not moving very fast. And so if somebody's sitting on the toilet or lifting heavy weights for a long period of time and the blood just pools in the hemorrhoids, it can spontaneously coagulate. A general algorithm for managing hemorrhoids that's pretty straightforward is, first you identify the specific symptoms people are having, because all management of hemorrhoid conditions is just directed towards those symptoms, whether it be bleeding, itching, or pain. I confirm that source on exam with the 4 steps I outlined. Once you've confirmed what the issue is, you can look at the range of medical therapy as well as procedural therapy that may benefit it. Generally, people will start out trying the basic things to make it better. Medical therapy is usually just directed towards decreasing vascular congestion. A simple experiment that I show people in the office all the time is if you drop your hand below your heart, you can sometimes see all the veins in your hand swell up. And when you raise your hand above your heart, you'll see that the veins instantly collapse and all those hand veins just disappear. And the same thing happens with your hemorrhoids. When you sit on the toilet, your hemorrhoids will swell and swell and swell just because they're sitting in an open circle. And when you get off and you're sitting down or doing other things, the blood is able to more easily, escape the hemorrhoids. And so spending less time on the toilet obviously is to the benefit. Straining less is also will decrease hemorrhoid congestion. Sometimes when people have some skin irritation from prolapse, using like a skin protectant is something that's easy. This is the most common thing that I recommend. It's a very bland skin protectant that can be picked up at CVS or Walgreens called Balneol. There are many, many other similar formulations. People use anything from Vaseline to camelseptine creams to many things, suffice it to say. But the most important thing is to let people know that hemorrhoids are not dangerous to them. It's not cancer. It's not something that will affect the quantity of life, but hemorrhoids obviously can cause a lot of quality of life issues, and that's the point of treating it. When people do proceed on to some sort of procedural therapy, it always just is a thoughtful history and exam to understand what symptoms are bothering people the most. People can have external hemorrhoids that don't bother them and internal hemorrhoids that do, and vice versa. I can see people with very large hemorrhoids that barely know they're there. I can see people with very small hemorrhoids that are insanely bothered by them. So you just focus on and give options that correlate and will manage the issues that people have. So again, the simple philosophy, everybody has hemorrhoids. These hemorrhoids will stretch over time related to aging. We'll create a variety of symptomatology. We just focus on those symptoms and aim to improve people's quality of life. Reassurance is often the best thing to do. There are a couple notable exceptions. Some people on anticoagulation can actually have life-threatening bleeding, and a few times a year, somebody will be in the hospital and be getting blood transfusions for very severe life-threatening bleeding from hemorrhoids. It's more the exception than the rule. And there is also a condition where people can have extreme prolapse and thrombosis of their hemorrhoids, which can lead to cell death called necrosis, and that can also be a surgical emergency. I believe the next picture will show that, so if anyone wants to turn their screen off, they're welcome to. It might be one of the next few slides. I'll try and warn you adequately. Internal hemorrhoids can be graded into the degree of prolapse. That's something we commonly do, which helps us make decisions about it. And just getting on to the different procedural choices, oftentimes we can do office-based procedures such as rubber band ligation, injection sclerotherapy, infrared coagulation, basically where you can pinch burn or squeeze the internal hemorrhoids. But the surgical procedures tend to be more aggressive in the operating room. Excisional hemorrhoidectomy still being a gold standard where you simply just remove the abnormal hemorrhoid bundles. More modern procedures where you simply ligate the blood vessels called THD, and then there's a procedure that's been around for a long time now called a stapled anopexy, otherwise known as PPH. So this is just an example of a common problem that people have with the external hemorrhoids, where they can just have a simple thrombosed hemorrhoid. So this is an acute condition where people will have severe pain and feel like a grape or a lump is on their bottom. Sometimes people will think it's actually poking out, but it's an external hemorrhoid. As you can see, it's covered by normal skin on the outside. Most of the time, this does not require any surgical therapy and can just be treated with doing some hot baths, some stool softeners, and taking some light pain medicine, usually NSAIDs or Tylenol. On occasion, if people are in severe discomfort, there is some benefit to simply removing it. I do not recommend a simple incision and drainage, as that will not remove nor prevent this happening from happening again. Most often I perform this in the office. So if somebody has one of these issues, they call and we usually will get them into the office within 24 hours, if not the same day. knowing that time is typically of the essence if you want anything done. So I'm sorry, this was the picture I was trying to warn you about before. This is an example of severe thrombosed hemorrhoids of both the internal and external. You'll see the external hemorrhoids are covered by normal skin, and the more glistening part in the center are the internal hemorrhoids, which are severely prolapsed. You can see there's black areas and sort of this fibrin debris on the outside, which just goes to show you there's a severe inflammatory response occurring due to strangulation of the tissue. I'm just going to show some pictures of some of the procedures just to give you an idea of what they are. This is just some of the equipment we use for rubber band ligation. The procedure is pretty simple and done in the office, where we simply grasp or use a suction machine to suck one of the hemorrhoids into this bander, where we then deploy a rubber band which bands the internal hemorrhoids. Again, that occurs above that line that I was describing before, where the innervation is different, because below this line you would feel like someone was pitching you, and above this line you do not feel that. Sometimes people will describe a little pressure, but not any pinching type severe pain. And here's a picture of what that might look like on the inside. For more severe cases, hemorrhoidectomy can be needed if people have very, very large internal hemorrhoids, have a hemorrhoid crisis like I showed you before, or anybody with large external hemorrhoids that are symptomatic. Because the external hemorrhoids are covered by normal skin and have normal innervation, you can't just simply put a rubber band on it or inject it or do any of those sorts of procedures due to the fact of the way it's innervated. This is just a diagram of a typical excisional hemorrhoidectomy. Typically, we'll just remove an oval area of the excess tissue, excise it. There are a variety of ways that we do this, either sharply with scissors or with cautery or other modern devices like something called a ligature. Here's a picture of the PPH surgery that I was describing before, where if people have very large prolapsing internal hemorrhoids, they can have a stapling device inserted into the anus under anesthesia, which will create a staple line on the inside and remove and pexy the inside of the anal canal. This is not a procedure I personally typically like. There are many practitioners who perform this excellently, but it does have the highest complication rate in general of the variety of hemorrhoid procedures. And there are many viable alternatives to this. So I feel like it's being less frequently used today than previously. There's some unique issues that can happen, such as issues with the staple line. People can get some narrowing from excessive scar, chronic pain. If the staple line is too wide, I've seen it catch people's muscle. I've personally seen a lot of referrals from folks for treatment of complications that have happened elsewhere for this problem. And I've done a variety of procedures, from strictureplasties, where you have to basically open up a stricture that had narrowed too much, where it was hard for people to move their bowels. I've removed the entire staple line in some folks, where the staple line was placed too deep and in catching some of the sphincter muscle. I've also done more minor things where they've just had some residual inflammation from it. I've done things like Botox or local steroid injections to just treat some residual symptoms related to that procedure. So I'm personally not a big fan of it, but there's certainly people around who probably do an excellent job with it, and patients that have had success nonetheless. There are some things I didn't discuss with hemorrhoids. You notice I haven't really mentioned cortisone creams or preparation H. These are very common things people will go and seek out on their own. It's actually very rare for hemorrhoids to be inflamed. On occasion, I will see hemorrhoids that do have an inflammatory component to them, but cortisone creams really are useful for conditions like itching, or if there's associated inflammation, and most people with hemorrhoids don't have that, so they don't see a real benefit from the cortisone creams. Preparation H has an active ingredient, which is phenylephrine in most formulations of it. Sometimes it just has lidocaine in it, which is in general what I recommend is a pure lidocaine cream. You can often save some money from buying stuff that's from avoiding buying stuff that's not necessary in most cases. And I have a video from an old commercial in the 1980s with Bryan Cranston, who you probably know from Breaking Bad, where he is showing preparation H, and the sound may not work, but what I'm going to show you will certainly be enough here. Bear with me. So in this video, Bryan Cranston is selling Preparation H on the basis of its, quote, oxygen action. I've certainly never learned of any oxygen action, and nor is any medicine sold in the modern day. And the reason why with that as a prescribed reason to do so, and the reason why I show this is because many of the over-the-counter medicines in proctology have predated randomized trials in modern medicine. Many of the laxatives on the aisle have been used in humanity for well over 100 years, and they're sort of all grandfathered in. And some of the older a lot of the information you might look up can be very easily dated on that stuff. So personally, I would say if you have questions about that stuff, you should ask your physician and not simply go to the pharmacy aisle and sort of treat that as you know, as a way to diagnose and self-treat. So some final takeaways about hemorrhoids. It's a benign condition. Some serious ones should be ruled out by proper exam. Education and reassurance is the most important. Treatment is customized to symptoms. There are a few urgent indications for surgery, as I noted. And of course, the pharmacy shelf is not a cure-all despite all of that oxygen action. Okay, the next thing we're going to talk about is anal fissures. This is when people can get a tear in the anal canal. So the anal canal is actually a bit of an ellipse, and the way it is, it's not simply a purse string that narrows down when you have continence. And so it turns out that the front and the back of the anal canal are areas of the highest pressure where the blood flow, actually the way that the blood vessels work around the anal canal also ends up being the lowest area of blood flow in general. And it's highly susceptible to getting torn in those spots when people pass a very large bowel movement. There are some unusual causes of fissures, and so something to be aware of is it really does take a focused exam to be able to differentiate. There are a number of times where people can have what they think is a symptom, and they'll really have something like an anal cancer or an infection, which can masquerade as that. So a proper exam is always necessary to make sure that you have the right diagnosis. The most common reasons for a fissure are a simple traumatic tear, like passing a large hard stool can be the thing that most commonly happens. Something that's less described when you read about the topic is that some people will get tears not even passing a hard stool, but just because they're either having frequent diarrhea or their skin on their bottom is very dry. And as you can imagine, if you have chapped lips and you pass even a normal, or you're trying to eat something and your lips are chapped, even eating something small might cause a tear in your lips. And likewise, if you're moving your bowels, something similar can happen below, which can initiate the tear. As a result of the tear, you can get a lot of spasm of your sphincter muscle, and that can result in diminished blood flow to the area, which makes it hard to heal. And so there's a classic diagram here where first the initial trauma happens, and then you can get irritation to the muscle underneath because the tear happens right on top of the muscle, and that leads to muscle spasm, which then can lower the blood flow to the area and result in the ulcer not healing. Okay, and suffice to say, there were a lot of studies done in the 90s and 80s which looked at this that allowed us to find out why this happens. And this is a simple graph of blood flow versus pressure in the anal canal, and shows that blood flow goes down as the anal pressure rises, making some people more susceptible to this. So again, just comparing it to hemorrhoids and everything else I've mentioned so far, you get a lot of the same symptoms with anal fissures. People tend to be in a lot more pain with anal fissures than almost anything else. They can describe a lot of spasms, sometimes some bright red bleeding from their bottom. Sometimes they'll see some soilage. The higher up the fissure is, the less pain they'll have. Whereas if the tear is right on the skin on the outside, usually that's very, very tender. You can classify these into whether they're acute or chronic. That's useful for me as a clinician because when they're acute, they're very likely to get better. Well over 90% of acute tears will get better with simple medical management. But once these have been around for a while and have some other findings of chronicity or damage, actually the chance that people will go on to need surgery is extremely high. This is just an example of a very severe fissure. And people, you know, the way I think about this and explain it to patients in the office is that, you know, if you have a big tear in it and you don't have enough blood flow in the middle to heal it, you end up just building all this heaped up tissue on the sides because you can't really fill the middle that easily. And that analogy helps people understand why you can get these large growths and tags around you know, around these fissures. In this person, you can see there's a very large tag on the outside and a very large tag on the inside due to that. And there are a variety of, you know, of findings that you can have like that for when these have been around for a very long time. In general, for fissures, symptomatic relief can just be done with soaking your bottom in hot water, which is very helpful for any anorectal condition, mostly. Stool softeners just to make bowel movements more easily, and you can use a topical medicine that has a muscle relaxer in to relax the anal muscle. We have done Botox injections on occasion when people fail that, but Botox was much more popular about 10 years ago and is a little less so now just because it hasn't shown to be you know, any more effective than the topical medicine, but it's still a nice alternative for major surgery if people are trying to avoid that. There are some major surgical options that are available. The most common, which is where we actually divide some of the muscle. And the reason why we do that is because by relaxing the anal muscle, you can improve the blood flow to heal the fissure and prevent it from happening, to essentially make it normal. There are some varieties to that procedure. You can avoid muscle cutting procedures in certain circumstances where you just debride the fissure, something called a fissurectomy, and you can add Botox to that. Or you could do more plastic surgery type procedures where you simply cover the ulcer. The effectiveness rates of that are on the lower end, but those are typically done for fissures that don't have very tight muscle associated with it. This is just a picture of a typical sphincterotomy. You can see in the picture there's some muscle that the scissors are about to cut, which represents the internal sphincter. Again, the takeaways for this: medical therapy is always first. This is benign disease, so the reason to treat it is simply that your quality of life is being significantly impaired by it. Sphincterotomy, which is one of the most common surgeries done for chronic anal fissures, remains safe and effective and can be used for most people. There are some exceptions, but coming to see us in the office to evaluate that would let us know if that was the case for you. And there are some less aggressive options if they need to be customized as such. Another topic is anal infections. You know, perianal and perirectal abscesses are also very common causes of anal pain. They can cause pain, swelling, drainage, bleeding, all the above. Every one of these has a same list. Urinary difficulties are very rare. That's typically a very bad sign. The most common etiology is just a random infection. People say, why did this happen to me? But the term for that is cryptoglandular, basically meaning that there's a little gland on the inside of the anal canal, which can get presumably clogged and cause an infection. Basically, I make an analogy that it's similar to like a pimple on your forehead kind of thing. But there are some more nefarious causes which can be ruled out with simple exam. This is basically the pathogenesis of the average infection, where you can get a small infection that starts in an anal gland, and then that can progress and enlarge. Eventually, that can be drained onto the skin. You can see that infections can be quite complicated in the bottom picture here. They can actually progress in any which direction. They can go through the anal muscle, they can come out between them, and they can move up in between the sphincter muscle and levators, and they can progress to a chronic form called a fistula, which I'll talk a little bit more about in a bit. So this is the chronic form of an abscess. So most abscesses, after you simply drain them, will just scar down. But in some circumstances, the tunnel from the anal gland on the inside to the hole on the outside will persist, and that is called a fistula, okay? When we simply drain an abscess, most of the time antibiotics are not necessary, but when people have some compelling comorbidities, we occasionally do add antibiotics. But a very common question, do I need antibiotics when I have an infection around my bottom? Most commonly, it's not required if we've removed all of the evidence of infection. That's a very dramatic picture I'm going to quickly go past, but that was an example of the most severe form of infection on your bottom called Fournier's gangrene. Moving on, So when it comes to fistulas, so when people have a chronic fistula, that's something that in general is not going to get better on its own. There's a number of different procedures that can be done depending on the severity of the fistula. The most important thing that we consider when deciding what procedure is how much muscle is involved, because we do not want to materially affect people's continence when they're moving their bowels. So people that have simple fistulas that do not involve a lot of the anal muscle can get something called a fistulotomy. What that is simply like this picture shows. You're making a cut from the outside all the way to the inside where the gland is, and you essentially debride or excise any of that abnormal tract and then allow it to heal from the bottom up like a wound. In certain circumstances, when people have a tract that wraps around a lot of muscle, that would materially cause incontinence if you performed such a procedure. And so you will do alternatives. And we have a number of procedures called like the lift procedure or a mucosal advancement flap, which I'll show you a couple pictures of. Which can be done under those circumstances. Those have a lower success rate, so fistulotomy remains one of the best procedures you can possibly do to definitively cure somebody of a fistula, and you really reserve those other procedures when people are going to be at risk of problems with their continence. One of the first things you do before you do one of those sphincter sparing surgeries, as we call them, is you place a little rubber band around them. And the purpose of that is you can have these amorphous cavities on the inside, and you would like the body to scar around it to create a fixed tunnel, which is easier to operate on. And so typically these will be left in for 4 to 6 weeks or longer in some circumstances before doing any definitive surgery on the fistula. This is a diagram of what's called the lift procedure. That stands for ligation of intersphincteric fistula tract. It's a mouthful, but it basically means you go in between the sphincter muscle to divide the tunnel that's there. This is another picture of it. So you have the tunnel going across the anal canal here, and the surgeon will go in between the muscle and divide it. As you can imagine, you're leaving some of the pathology behind in some circumstances, which is why the success rate would notably be less than a simple fistulotomy where you are removing all of the abnormal tissue. This is an example of a lift procedure that I've performed where the incision between them or between the muscles in the anal canal is here, and this is the external tract, which I've actually cored out the external tract, and then I've divided the internal tract over here. This is just an example of the mucosal advancement flap where you just excise the hole on the inside and simply advance some of the local tissue to cover it. Major lesson that I want you to walk away with about infections is after a surgeon drains an abscess, I can't tell you how many times in the office I see somebody who had something like this and then went on for 2 years to continue to have pus drain or blood tinged drainage around their bottom and not know that there was still a problem related to an abscess drainage that they had. So whenever you have symptoms that persist weeks or months after you've had an abscess drained around your bottom, you need to think that it's turned into the chronic variety of that, which is called a fistula. And know that fistula care is heavily customized to the findings on exam, as well as people's past medical history, because there are some unique problems that you can find when fistulas are caused by things like inflammatory bowel disease or cancer. I'm going to now rush a little quicker through the last couple things, but I do want to have a moment to talk about them. Another common problem people can have is rectal prolapse. This is when the rectum invaginates outside the anal canal. It can be often confused with hemorrhoids. There are a number of reasons why that happens. A lot of this just has to do with things stretching over time. This is a standard picture of rectal prolapse. You can see the rectum is actually invaginating outside of the body. People can have a variety of symptoms, which again matches up with a lot of the symptoms from the other conditions. People can have incontinence because the anal canal is not working and is widely spread open. Some people will have a history of constipation, which has caused them to sit on the toilet for long periods of time, which has resulted in this. They'll notice the protrusion. This area of mucosa can easily bleed, which can be a significant symptom that I see people for, and a lot of rectal pressure. Doctors like diagrams or descriptive terms rather. Sometimes we make analogies with food or other inanimate objects to describe things. And it's very common for us to, when we look at hemorrhoids and differentiating that from prolapse to those who don't have the educated eye, we can see these radial grooves along the hemorrhoids, and we call them like spokes on the wheel, these radial lines. And that tells you that this is an example of prolapsing hemorrhoids, whereas you can see these concentric circles, circular grooves around, and that's how you know that this is rectal prolapse. Oftentimes when people come in to be examined for this, I actually will bring patients into the bathroom and allow them to sit on the bathroom. So that way the pressure of that will allow it to prolapse, because this is something that I just have to see to diagnose. There are a number of ways that we fix this, one of which there are generally two ways. Some are through going through the abdomen to pull it back up. Sometimes that will include removing a part of the excess colon when there's a lot of redundancy. And there's also repairs that you can do from below in the event that people are extremely elderly or not able to tolerate general anesthesia. This is the most modern procedure that I perform, called a ventral mesh rectopexy. It involves placing mesh all the way at the bottom of the rectum, which you can see here. We place sutures along a mesh that is affixed to the anterior rectum, that is pulled up and then sutured to the bone in the back of the pelvis, okay? And then we close the lining of the inside of the body, called the peritoneum, over the top to keep the mesh from touching any other structures on the inside. There are a lot of benefits from this. People generally have a short stay in the hospital, just usually one night. In some circumstances, could go home the same day. And most of the time, we'll take advantage of one night in the hospital, just so people wake up from the anesthesia, and I can make sure that I give good post-op instructions when they're not, still under the influence of their anesthesia. Here's an example of a perineal repair that I performed. You can actually still get very large specimens. The perineal repairs generally will involve resecting some of the excess rectum at the bottom. The functional outcomes of this are generally poor in comparison to the other ones. There's a variety of reasons for that. In general, it has to do with losing the capacitance of the normal rectum, which again, as I was describing before, kind of acts a little bit like a bladder in terms of being able to stretch, whereas the rest of the colon doesn't have that. There's a bit of a higher recurrence rate with doing perineal repairs. I generally reserve them for people who are not candidates for abdominal surgery. And the last topic I'm going to run through is just talking about cancer, of course. Cancer certainly can occur in the anal canal. I had a patient just last week in his 50s who thought he had hemorrhoids, and in fact had a large anal cancer that had been growing there. Very common for people when I see them in the office to assume for months they were having a bad hemorrhoid that didn't get better. There are a variety of different malignancies that can happen in the anal canal and around the perianal skin. Just for example, this was a squamous cell carcinoma I treated that did not get better with a topical chemotherapeutic that I gave that ultimately required excision and a local flap. Some of the additional neoplasms that you can have inside the anal canal, like squamous cell carcinoma or a typical adenocarcinoma, like a rectal cancer. There's some other unusual ones that I've seen. This was an example of a benign angiofibroma in a young woman in their 40s, a completely benign tumor that unusually occurred between the internal and external sphincter muscle. The symptoms of anal neoplasms are the same as many of the other ones we've seen. And I really want to emphasize that. Bleeding, pain, presence of a lump on the outside, some itching and discharge. Unbelievably, well over half of the people I diagnosed with an anal cancer, thought it was a more benign condition prior to being seen. The exact treatment for anal neoplasms depends very widely. I showed you at least 8 different types of neoplasms, and the exact treatment for it will widely depend whether it's something that can be locally excised or simply treated with radiation, or whether there's something more complex that needs to be done. But it does require an appropriate evaluation to determine that. Okay, so I got through way more than I was expecting. I'm very happy about that. I hope that I was able to reduce some of your fear of seeing a proctologist, knowing that all of these conditions are very common. I do want to make the point that you can't really have a diagnosis unless somebody has looked at the area. And, if you're having a symptom on your bottom, if the worst thing that happens is you come and you get checked and you get reassurance, that's not a bad outcome. That's a good thing. and to just really emphasize the importance of an exam and evaluation to make sure you have a correct diagnosis. And now I'd like to open it up to any questions that people have.
Yeah, thank you so much, Dr. Bornstein. That was such a great presentation. And if, like you said, if anybody has any questions, you can enter them in the Q&A feature at the bottom of the screen. All questions are anonymous to protect your privacy. So we'll just give it a few moments here to see if anybody has any questions.
Good question. So people commonly ask about, do I have to press a button here to initiate? Can everyone still hear
you're
me?
good. Yeah,
Okay.
they can hear you.
So people often ask about what to eat or if food has anything to do with their hemorrhoids. But as I was describing, hemorrhoids, for example, are a pressure-mediated phenomenon, like just vascular congestion. So if things that you eat are causing constipation and then causing you to sit on the toilet for long periods of time, then yes, what you're eating will tend to produce worse if it produces worse bowel habits, it's going to cause symptoms and then make some of those problems worse. I don't specifically recommend any particular foods. I mean, the most common recommendation we give is to have a high fiber diet. Truthfully, that works for a lot of people. It doesn't work for some, so there's no simple bulletproof thing. If you have a diet that's well balanced, that has all the vitamins and minerals that you need, and your bowel habits are normal for you, that's fine. Something that's important is that there's no normal for the frequency of bowel habits that you're supposed to have. So people will ask, well, what is constipation? What is diarrhea? Well, it turns out that it's kind of a little bit in the eye of the beholder. Some people can move their bowels twice a day, and that's normal for them. Some people move their bowels once every 4 days, and that's normal for them. The important thing is that you're not having some symptom that bothers you. So if you're not moving your bowels for a week and you're having a lot of belly pain, well, then that's constipation from my perspective. If you move your bowels once every 3 days and you have no abdominal discomfort, and when you move your bowels, you have no pain or discomfort, then that's normal as far as I'm concerned. Hemorrhoid staining is often caused by prolapse, assuming that hemorrhoids are the actual cause. And so, sometimes when it's gotten to the point of staining, usually procedures come into the realm of what people want, because usually if they're having excess tissue that's coming out, you want to remove that excess tissue to make it go away. One way that you can prevent a lot of irritation from that is to just put like a barrier cream, like the Balneol, around your perianal skin. And that can protect the skin from burning and irritation. Very commonly, I'll tell people to put like the Balneol cream on their anus before they move their bowels, and that might prevent any of the burning or irritation that they have. So can I tell the difference between a hemorrhoid and a fissure without an exam? So I would say about 80% of the time when people tell me what symptoms they're having, I can 80% of the time make a diagnosis just on history alone from my experience, but I can't actually make an official diagnosis without the exam. You need to look. Some fissures, I've seen fissures that weren't fissures and they were resulting from an infection on the inside of the anus that you just couldn't see without feeling. I've seen cancers that can masquerade as fissures. I would say that you can't tell the difference between anything without an exam, truthfully. I have itching around my anus, no pain or bleeding. It is not an everyday occurrence, but it has not gone away after using petroleum jelly. So itching can be a difficult symptom to get a simple answer to. So I do have an algorithm that I approach pruritus, what we call it as pruritus ani with. Most of the time, it's hard to know what the incident cause of it was, because I'm gonna give you a long-winded discussion about this, but think of your perianal skin as sort of a special area. And this analogy might be a little disgusting, but bear with me. If you took stool and wiped it on your forearm, it's very likely you would get multiple infections along your forearm. You'd get multiple follicular infections from all that E. coli and burden. But that doesn't happen to your perianal skin, despite that you wipe and clean the area and it's exposed to fecal matter on a daily basis. Similarly, in your stomach, you have all of this stomach acid, but your stomach has a natural protective barrier to prevent the stomach acid from eroding into the stomach wall. But as you can imagine, some people will take medicines like NSAIDs or have something happen where they get sick, and the stomach, all of a sudden, the stomach lining no longer protects the stomach, and the acid starts to create things like gastric ulcers. Well, you can think of the perianal skin as the same thing. There's some cause that first caused the protective layer of the perianal skin to go away, and then the irritation starts. And then it can be very hard to get that itching to go away because there's this sort of trauma cycle that can then occur because you scratch and that denudes the skin more, then the itching persists. And so oftentimes what I'll do is I'll use a variety of creams, prescribed creams that have some antibiotics, some steroid, as well as some antifungal properties to just sort of hit it with the kitchen sink and see if I can get it to go away, with some more aggressive topical treatment. When it doesn't get better from that, you sometimes need to be a little thoughtful if there's some anatomic drivers, which otherwise won't be fixed, like if they have large prolapsing hemorrhoids, or if you're having lots of diarrhea, some other things might need to be corrected. And as I showed before, rarely there can be other primary skin conditions which need to be evaluated, or other medical conditions that might require something like a colonoscopy or a view inside the rectum to see if there's anything driving it still. But most of the time, I would say about 80% of people, just with a simple visit to see that nothing else is going on in a trial of empiric therapy with what my version of triple therapy for this area, it goes away.
All right, that looks like it was the last question. So I just wanted to, oh, wait, let's see. We have one more question.
Okay, bear with me. Resolve cyclically. So that's a good question. When people are elderly, let me say that there are no rules when it comes to what you have to do for yourself. Most of modern medicine has only existed for the last 50 years, and humanity has been on this planet much, much longer than that in the absence of doctors and colonoscopies, which really has only been happening for around the last 100 or so. And so the first thing you should recognize is when folks get older, they're not required to seek medical attention if it's not something they want for themselves. When it comes to stuff like bleeding, where I'm getting at this is that first being realistic on what your goals and what your family members' goals are, because if you're comfortable with not knowing something, that's when it's okay to not do something. When they say if somebody's having bleeding, it's true, a colonoscopy is the only way to fully evaluate the colon and know that there's not, then the whole list of things that could possibly be aren't happening. When I see somebody in that circumstance, what I can do is sometimes people will say, I don't want a colonoscopy under any circumstance, but if I examine the person and I see a hemorrhoid and I see that hemorrhoid's bleeding, I can still treat that hemorrhoid, and we can decide between ourselves whether that's sufficient for what one wants. I will never make a promise that that could be the only thing happening, but in a lot of circumstances, people are very happy with sort of abbreviated workups, understanding the limitations to that. So you just have to be, when not performing sort of the most aggressive range of workup, you just have to be aware of what the limitations of that might be. And so seeing a practice, I certainly see conditions exactly like this and manage bleeding locally if I see a bleeding hemorrhoid. But I would never make a promise that there couldn't also be a rectal cancer or colon cancer without more invasive endoscopic exam. But I'm perfectly comfortable with people choosing to not do those things as long as they're aware.
All right, so it looks like our time is up here. I just wanted to thank everybody for joining, and thank you again, Dr. Bornstein, for your great presentation. If anybody has any additional questions, you can email them off to matherhospital@northwell.edu. Once you exit the webinar, you will see a link to complete a brief survey. If you can complete that survey for us, your feedback is extremely important to us and helps us plan our future programs. I just wanted to, again, thank you all for joining. And if you'd like to view past HealthyU webinars, you can see them at www.matherhospital.org/HealthyU. Thank you all again. Thank you, Dr. Bornstein. I hope everybody has a great day.
Thank you very much. Thank you for having me.